Hi, I'm Mary Ellen Roberts, and I'm a doctor of nursing practice. I'm certified as an adult and an acute care nurse practitioner. My topic today is atrial fibrillation and stroke prevention. So why do we need to prevent stroke? Well, we all know why we need to prevent stroke, because we don't want any mortality outcomes for our patients when they develop stroke. However, patients with atrial fib have a greater risk of developing ischemic stroke because of the atrial fib. So one of the things that we need to do is make sure that we diagnose atrial fib early. Diagnosis of atrial fib is done primarily through EKG. Unfortunately, with atrial fib, most patients don't know they have it, and oftentimes we don't find the atrial fib until a stroke does occur. So patients who would come in to you complaining of a fluttering or palpitations, or they just don't feel good, they can't walk like they used to walk. Somebody who walked 1 to 2 miles is now maybe walking a half a block and can't walk that further. We need to investigate this. If our EKG comes back, our simple EKG comes back in normal sinus rhythm, then we need to go further. And at that point, I would make sure that I did Holter monitoring to make sure that we monitor this patient over a period of 24 to 48 hours, and in some cases longer. If the patient does have atrial fib, then there's several steps that we have to take to see if they need anticoagulation. Anticoagulation is the earmark of prevention of stroke in these patients with atrial fib. So the first thing we want to do is do a CHAD score. And the CHAD score will help us determine if the patient is at risk for stroke. And then the next thing we want to do is a HAS-BLED score, which again will look at what risk the patient is for bleeding. These two scores are highly recommended by the 2014 guidelines of ACC and AHA. In doing that, once we do that and we determine that the patient is at risk for stroke, then we need to determine which anticoagulant to put them on. Well, there's Warfarin, which we all know well, has been out there for a very long time, and it was the drug of choice until the new novel drugs became available: dabigatran, rivaroxaban, and abixapan. Those three drugs, these three new novel drugs, have changed the landscape of how we treat patients with AFib in determining prevention of stroke. Any of those new therapies will work. However, in looking at those new therapies, we need to determine the efficacy within the patient. We need to talk to our patients about it. We need to look at shared decision making, which is really a hallmark of care in these patients as to which drug we're going to put them on. In addition, we need to look at comorbidities that they may have. We need to look at drug-drug interaction with these medications. And we also need to look at any side effects that may occur. It is known, we do know that the new novel drugs do have less side effects and GI intolerability than some of the other, than Warfarin does. Dabigatran will cause some gastritis in some patients. The other thing that is important to know is there's a new reversal agent out there which was approved in October of 2014 called Praxibine. And Praxibine is specifically used for dabigatran to reverse anticoagulation in someone who has excessive bleeding or somebody who needs to go under emergent surgery or a diagnostic procedure. My three takeaways for this talk would be: first and foremost, shared decision making. Talk to these patients about their options for drug therapy. Talk to them about their lifestyle. To really get to know the different drugs that are out there for anticoagulation, particularly the three new novel drugs, and what we can and can't do with them, and when we should and shouldn't prescribe them. And to really give the patient back a quality of life that they that they would want and what they deserve. And by doing that, by looking at the CHAD score, by looking at HAS-BLED, and by looking at their overall and doing holistic health with these patients, we can give them a quality of life that is well deserved, and one that in which they can continue to live and be without stroke for years to come.